HPI here a little bit and let them ask some questions. Sorry, there's an echo, so I'll move out of this room. So we have a patient that's presenting with altered mental status. He's a 45-year-old man with history of ITP, splenectomy, T-cell lymphoma. And do you want me to go on, or should we just stop it there and have them ask questions, Danny?
Yeah, so, hey, Devang, why don't you just kind of just give us the highlights of the HPI, like the big things that you think we should know, and then we'll just kind of ask questions if they need any things to be elucidated on.
Sure. So this guy was in his usual state of health until his symptoms started abruptly at 7 a.m. He had a rapidly worsening course during that time. And then his wife brought him into the emergency department. And that was by ambulance. In the ED, the patient was found to be unresponsive. So let's take it from there. I think let's just emphasize diagnosis and also initial management here.
Yeah. So great, Devang, that's great. I think that leaves, obviously this is like a pretty ambiguous where we are right now. And I like having where we are and kind of what questions we would be going with. And so leading to our three discussants, Dr. John, Dr. Behan, Dr. Paek, I want to hear from you guys. What questions would you be asking, or what do you want to know from this patient with him in the ER?
What were his symptoms initially? Was it literally he just was altered, or did he complain of anything?
Yeah, that was literally it. He was fine, and then just in the morning, his wife couldn't wake him up. He tried to get up to go to the bathroom, and he could not, and then progressively got more somnolent.
Yeah, what are his vital signs right now?
Right now, that is a great question. Heart rate's normal. BP is 100/60, and his temperature is 100.4, and he is setting in the 40%.
Okay, so I think what my colleague Dr. Behan was alluding to, I think one of the most important questions that we need to ask whenever we're assessing a patient is if a person is sick or if they're not sick. And this topic comes up, and it's a little hard to explain sometimes, but the way I kind of think about it is there something that's going on with the patient that if we don't intervene urgently, life or limb could be at stake. So a common way we approach that is we're looking at the ABCs, airway, breathing, circulation, and our first step to that is looking at the vitals. I will be the first to express some concern with these stats of 40%.
Yeah, the waveform doesn't look great, but he's in the 40s and just sitting between there and the low 80s now.
Oh, cool. Just so we kind of, and I love the fact that you guys are kind of having the conversation with the ED provider, which is great, and that's totally goes with how we usually do it. But just to kind of like keep it in kind of a sequential, just in this format. Anything else you guys want to know about this guy from his HPI, more than like past Melgers, or really just his HPI stuff?
Yeah, I mean, like, what do we mean? I would like a little more clarity on unresponsive. Like, is he sternal rub only? Is he like grunting? Like just an idea of like sort of where his GCS is at, and then if possible, if like there's collateral on what his baseline is at.
Sure. Baseline, he's ANO times 4. He's able to manage some of his ADLs, but he just has some neuropathy in the legs. Right now, he is awakening to sternal rub, opening his eyes, and just grunting. He is able to move his extremities slightly and does follow some commands.
Okay.
Perfect.
Another thing that I like to think about when assessing a patient and something that's happened to them, because it often gets lost down the road, is this something that we did to the patient as a medical community? So I'd be very interested in, we're probably going to go through this, his medications, but specifically if there's been any recent like medication changes, if he's started new meds. And then the other thing to think about is if he's had any kind of recent procedure, any kind of like medical intervention, recent hospitalization. That's really good to know historically to then correlate with what we find on exam and objective data?
That is an excellent question. He was recently admitted for MRSA cellulitis in his right hip, no osteomyelitis, and he was put on Bactrim for that. He has just finished his course of that. And then, do you want me to just run through his med list?
So, hey, why don't we, just so we kind of keep the format, I think that's good to like have like recent hospitalizations, but I think we've got a good idea of the HPI. But why don't we just kind of go through any like pertinent things you guys want to know about his past medical history and anything else on his social, family, and med stuff.
Great. So basically, I've gone over his medical issues in the HPI. There's nothing else to report there of significance. And then other than this total splenectomy, he's just had an abdominal hernia repair. In terms of family history, does have a history of rheumatoid arthritis in mom. And then otherwise, grandparent had a heart attack, but it was not early. In terms of social history, he actually is pretty functional at baseline. He's relatively independent in his ADLs, but as I mentioned, he can't move his legs. He's still able to work as a federal agent, but he needs to use a wheelchair. Doesn't use any drugs, no alcohol, and never smoker.
So, Devang, I'm going to stop you right there. So what's pretty interesting? I mean, there's a lot of interesting stuff about this guy. What's interesting about what we just kind of learned about with him to the people who are his who are our discussants?
This is so far, this is a pretty acute decompensation, it sounds like, from a guy that's relatively functional, right? To unresponsive with, the reason I asked for vital signs is I was suspecting significant abnormalities from a guy that previously was pretty functioning. So this is a pretty significant decline.
I have a couple clarifying questions about his recent past medical history. So MRSA cellulitis, how did we know for a fact that it was MRSA? Was he bacteremic with MRSA? Was there a wound culture? Is this like slam dunk MRSA cellulitis?
So there was actually just a wound culture. He was never bacteremic.
And then did he get better with this Bactrim that he was prescribed?
Yeah, he did. He still has a fever right now, but his cellulitis looks better.
So, Dave, one of the things I was kind of alluding at too. I think that's good. All these are great points and great questions. But one of the things that's a little bit odd in this guy's story, which I wanted to kind of throw at you guys, is they say from what Devang was saying is that he actually has such bad neuropathy that he's wheelchair bound, which is pretty odd, right? That's pretty interesting to me that this guy would be wheelchair bound from neuropathy. And why does this guy have such bad neuropathy? And then is this and I guess like alluding to like how long has he been in this kind of state and condition?
Yeah, and actually that's a great question. He was on various chemotherapeutic medications. Most recently he was on nivolumab and epoch. He said that's about the time that he really started to develop these problems, and that was a couple of years ago.
So kind of one of the other like kind of clarifying questions is, and you kind of were alluding to that, is, you put in the history he's got lymphoma, and I guess whenever anybody has cancer, one of the things we always want to know is, A, how long ago was it? B, are they in remission? C, what treatments did they have, and when did they get these treatments? Because then we have to think about complications that could happen years down the road, pretty acutely, depending on when they got their treatment and how long ago, and how severe their cancer is, and what type of cancer they had as well.
Yeah. So he has the angioimmunoblastic T-cell lymphoma. So it was actually recently diagnosed in 2007 is where they had some concern for lymphoma. The treatment for that did not begin until 2019, and he's presenting now in the beginning of 2020. And he had a PET CT done that did demonstrate 1 to 3 centimeter nodes, and there were multiple of them. I don't have the scan in front of me. And he, just notably, this isn't for his cancer history, but for his ITP, he was given steroids, and that was starting in 1987. And he's continued to suffer from that. He was also given Nplate to stimulate his platelet production. And that has kind of been constant since then. He was also given some IVIG in 2018.
And Devang, when did you say you last got the nivolumab and EPOC? And could you remind us all? You know, clearly all of us mostly know this, but could you just remind us all what EPOC is?
So, Jason, I actually don't remember exactly what's in EPOC. It is the chemo regimen for this lymphoma. Nivolumab he last got in January, and that was 1 month prior to admission. One of the chiefs help us out here with what's exactly in EPOC.
Okay. So while they're getting that answer for us, just like a couple quick comments. Nivolumab, I do know I do not know what's an EPOC. I was not a answer my own question type situation, but like nivolumab, I know is one of the PD-L1 inhibitors. So it's an immune checkpoint inhibitor used in various cancers, and it can cause, obviously it's used because it is effective in certain cancers, but it does two things. One, it leaves people in an immunosuppressed state. So in addition to his splenectomy, in addition to his lymphoma, it's another reason why this gentleman may have some kind of underlying immunosuppression, putting him at risk for infections that other people don't get. And the other thing that can go wrong with the checkpoint inhibitors specifically is they can cause some very gnarly autoimmune reactions. Pretty much any organ system, you can get an itis of it. And it can be pretty darn severe if it happens. And I think 1 month since the last dose is well within the time frame where some kind of autoimmune process could very much be in the differential.
Yeah, so these are all great points, and so that I think we should just cover his medication regimen at this point. Due to his immunosuppression, he is on suppressive acyclovir as well as Baraclude and Ticavir, and Cresemba, that's for fungal. So the first two are for viral. Cresemba is for fungal infection. And he's also on Levaquin. So he's on quite a few prophylactic meds. And then Corey, Danny, do you want me to just go over the rest of his meds at this point?
No, I think those are probably anyone that is like pretty contributory to the case at all.
Yeah. Otherwise, Sean and Jason, do you want to know about any other specific types of meds that he could be on?
Is he on opiates? Is he on any centrally acting medications given his penetration? Yeah.
Yeah. He's on 45 mg of MS Contin BID. And that's been a stable dose for at least 4 months.
Okay.
So yeah, just one thought about that. We're gonna probably get some lab work here in a bit. Sounds like he's been on a stable dose of narcotics, but morphine is at least partially renally metabolized. So if there's been any change in his kidney function, that could be a reason why a stable dose of morphine is now causing acute encephalopathy.
Yeah, good. That's actually a really good point. And I think so. Just so we can get everybody on the same kind of caught up to where we are right now, could one of you guys give me a problem representation of this patient right now?
Yeah, sure. So this is a 45-year-old guy, history of ITP, splenectomy, lymphoma, who is with also, I might add, significant neuropathy and wheelchair bound, who is presenting with acute obtundation, essentially. Sounds like in the past, like 24 hours or so, with, I mean, I can throw the vitals in there too, because they're there, with found to be normotensive and severely hypoxic on room air.
Yeah. So, so just from like looking at those vitals, what do you guys, if you had a guy who's immunosuppressed coming in altered, what would you, with these kind of vitals, what would you be most concerned for in him?
So I think his vitals are a little interesting. He, in particularly someone that's untended, shock, particularly septic shock, is super high on the list. But he doesn't have the blood pressure or heart rate abnormalities that are as suggestive as that. It's more of a hypoxic picture. So I would think of other causes that may cause a profound hypoxemia as the cause of this presentation in particular.
So what would you want to kind of, how would you want to dig deeper into what you were talking about, this hypoxia?
Yeah, so I mean, on everybody with hypoxia, like a good thing to get, Jeremy Hua always taught me ACE, so ABG, chest X-ray, and electrocardiography. Those are all good things to get. Those are the first three I would get.
I like that. Sounds good. Well, just to kind of keep things going, why don't we go through the physical exam of anything like the pertinent stuff, Devang?
I don't know if he has any focal findings in particular. It would be one thing. But.
Yeah. Good.
Yeah, sure. So he he appears sedated. I think I've already mentioned the neuro exam before. He is waking up to sternal rub, and he is following some basic commands. His lungs sound clear bilaterally, and then he has the regular rate and rhythm, no murmurs, rubs, or gallops. And then on MSK exam, he does have trace edema bilaterally. It is pitting, symmetric. And then on his, in his extremities, cool left leg, right leg warm, not that much of a significant difference. And then just evaluating that previous cellulitis, he had a 5 millimeter scab on the buttock without erythema, discharge, or warmth.
I just want to butt in with a few quick comments. So another couple things that we now shifting more towards like a differential for acute hypoxemic respiratory failure. And then, we'll try to correlate with the exam. Some things that he is at higher risk for compared to the general population is one, immunosuppressed, so PJP, PJP pneumonia. And I noticed that he had a course of Bactrim for the MRSA. I don't know if he was on PJP prophylaxis before he went to the hospital for Bactrim, or before he went to the hospital for the cellulitis, but it looks like he came out of the hospital not on that. That's classically associated with really profound hypoxemia. The other thing that would potentially represent an acute hypoxemia in him that he'd be at higher risk for is a pulmonary embolism. And if I recall correctly on his, he doesn't have a history of VTE and he doesn't look like he's on anticoagulation. Now tying that with the physical exam, his lungs sound clear. That would be consistent with a PE potentially. And then if he truly has like cool extremities, could be looking at an evolving like obstructive shock picture.
Yeah. So I guess what do you guys? I'll kind of punt this to you guys. What do you all think about whenever you hear a cool extremity? What are the things that kind of go through your mind? Because I think that's something that we should all kind of think about, because that can be kind of an emergent situation.
Yeah, is it yeah, I mean, if it's multiple, so first of all, is it single extremity? Is it multiple? Sort of like characterization of it. You know, because your thought process and differential will be different. But it sounds like this guy's got bilateral extremity that are cool. So shock is definitely one of the things I think about. Is his core temperature cold in general? You know, but that would be one other thing. But I think shock is definitely the first thing that comes to mind.
It actually sounds like he has asymmetric cool extremities, more so on the left leg. So I'd be worried about ischemic leg injury, like compartment syndrome, things like that.
And just to kind of, before we move, kind of keep going forward, when you say shock, is there a particular shock you think about?
Yeah, sorry, cardiogenic shock. Yeah, that cardiogenic shock in particular. Sorry, yeah.
And so, Michelle, you were kind of getting at, he's got unilateral leg coolness. What do you think about with that?
Yeah, I was worrying more about like ischemic leg injury, potentially developing like compartment syndrome, something like that, and whether you need an urgent like vascular surgery consult.
Yeah. So what would you check for to make sure this guy? I think that's perfect. What do you? And that's the thing you always think about when I think about cool extremity. What do you always look for?
You want to check pulses, and you can use a Doppler too if they have like peripheral artery disease.
Perfect. Yeah. So if you can't, I think that's a good lesson. If you can't palpate a pulse, and I think honestly, when you do an admission, palpating pulse is so quick. I think everybody should check their pulses. If you're not able to palpate a pulse, that is concerning. And then I would get a Doppler. I would go to the nurse's station, get a Doppler to make sure they actually do have pulses there, especially if they don't have any reason to not have pulses.
So I can just answer that question now. In the right leg, both dorsalis pedis and posterior tibial pulses are 2+. In the left, they're both 1+.
Yeah.
Okay.
Perfect. Okay. Anything else you guys want from the physical exam?
Did they check like pupils or cranial nerves at all? Like I'm worried about intracranial abnormalities that could be causing his acute presentation with encephalopathy.
Sure, yeah. His pupils are actually, they are 2 millimeters each, but they are reactive, just small. And then otherwise, he does react to sensation to noxious stimuli in all regions of cranial nerve 5, and then also in the extremities. It's a little hard to assess the motor function right now due to his significant sedation.
I think the only other thing I'd be wondering about, so like, you know, with the unilateral cold leg and a concern for like acute limb ischemia and potentially, you know, it could have been a plaque rupture there. It also could be embolic disease. So is there any other evidence on physical exam, particularly in the hands, of like embolic disease? So looking for like Janeway lesions, Osler node, stuff like that?
No, none of those.
Yeah,
So just to keep things moving, why don't we? So we obviously have the basic labs that probably that the ED is for sure. Are there any other labs that you want to add on to this before we start going through them?
What lab?
So David, while they're thinking about it, why don't you just read off these labs, and if we'll just add them on.
ABG.
Sure. Oh, you want to? Yeah. We'll just go in order. Hemoglobin is 10.3. White count is sorry, I don't have that one written down. Let's say 4. Platelets are 7. And then his BMP is just notable for the sodium's 135, K is 4.7, chloride is 102, BUN 33, creatinine 2.0, calcium's 9. And then his LFTs, let's just do notable ones. AST 136, ALT 82. His INR is 1.4. And then you wanted an ABG, so you got it. pH is 7.30. And then his piece, actually, sorry, we do not have an ABG. He was so unstable, we just got a VBG here. His pH is 7.3, PCO2 is 40, and O2 SAT is 56%, but it's venous side.
And did he get a, the only other thing I would think like possibly also would be like a UA, did he, I don't know if that showed anything, I'm not as suspicious, but did he get a UA?
Yeah, we sent it off. It's cooking right now. It's gonna come back unremarkable.
Perfect.
Did you mention what his bicarb was with the BMP? Sorry if I missed it.
Yeah, it's actually, bicarb is actually normal, say 24.
And what are his like baseline platelets and creatinine?
Great question. His baseline platelets are right in the 10 or below range, and his baseline creatinine is 1.8.
I mean, I
think
think
I would
that's
check like a CK to look for limb injury with the elevated AST as well.
We actually didn't check that.
Okay.
And did you get a drug screen on this gentleman?
Positive for opiates.
Yeah. Okay.
Okay. Any other big labs that you guys want to order while you're thinking about it, or are y'all ready to move on to imaging?
You guys check a TSH?
Yeah, it'll come back normal. We actually also sent off some cultures here. Sent off a couple blood cultures and urine culture as a reflex to the UA, although the UA ended up being normal.
Oh, okay.
Okay, so am I unmuted? So hey, so I'm gonna so I want to see what do y'all want for imaging now?
Chest X-ray first, probably.
And then
CT head.
perfect. All right. So the one that we actually we can read ourselves will be the chest X-ray. So I'll pull that up right now and share my screen.
Excellent.
Devang, is it the 1.8 or the 123 admission?
The 1.8.
So I'm going to give you guys like 20 seconds, but I want somebody to just give me a quick read of what they see, just kind of their overall impression.
Yeah, no, honestly, this doesn't look like much. You might have some subtle bibasilar opacities, but that I might be reading that a little bit, but honestly, I would say this doesn't look huge.
What is, if you see a chest X-ray, what's kind of one of the first things you do when you pull up somebody's chest X-ray?
Yeah, I mean, do you want to take time? I don't want to answer all the things. Yeah, I mean, you look at, in this guy in particular, look at the airway. Does it appear in the midline? Does there appear to be any obvious like airway narrowing? Would be something you can occasionally see. You can look for, everyone has their different approaches. The ABCDE approach is totally fine. Bones, like grossly, I'm looking at a phone, I can't really see any acute fractures though. Obviously the cardiac silhouette is not enlarged or shifted in any way. don't see any sign concerning like a cardiac effusion or anything like that. His diaphragms are pretty grossly sharp, and the fields themselves, like I said, maybe some potential bibasilar opacities, but not much else. And I don't see anything around the hilum that seems abnormal to me in particular.
Yeah, Sean, I think that was actually a really good read. I honestly I agree. It, pretty much for the most part, it looks like a clear chest X-ray. Looks like some, maybe especially in that right lower lobe, you can see some kind of opacification there. The formal read of this chest X-ray was unchanged irregular right. Yeah, you guys can see it, but basilar opacities. So pretty much an unchanged chest X-ray from previous.
Okay.
So what would you guys want to do now? CT head, that's right. So looks like CT brain doesn't have any acute intracranial process going on.
I think this is also a potential case where you could make the argument to maybe not get a CT of this guy's head. It's not the highest yield of a test anyway, in a guy that's grossly attended. Again, being a phone, I can't see any grossly focal on his exam. He does have the history of malignancy, which is something. So, I mean, that's definitely speaking for it. But just in general, a guy that's grossly attended, CT head is not always like indicated in someone that's non-focal with acute neurologic change like that.
And I agree. I think you put out some really good points. I think the one thing with this guy is because he doesn't have a great focal exam, and even though his pupils are fine, he's not like throwing up to make you think of elevated ICP.
Sure. Right.
I think it's one of these. You can go either way with it. I think Michelle choosing to get a CT head makes sense, but I don't think it's unreasonable to get a CT head. So
yeah, I'd also be worried about like brain bleed or something with his platelets that low, so I'd want to rule that out.
So what I want you guys to do is I want you guys, tell me what y'all's differential for this guy is right now. And then after you guys lay out your differential, I want y'all to tell me what you want to do from here.
I'll get things started with a differential. I think one thing, with a recent MRSA infection, this could be MRSA bacteremia. So sepsis secondary to MRSA bacteremia. And the other thing that I'll throw out there, I'll throw two more things out there. I'll throw a pulmonary embolism out there. And I will also, it doesn't really correlate with the leg, but I'll throw like an autoimmune encephalitis out there from the PD-L1 inhibitor.
Yeah, I think I'd want to rule out like a encephalitis meningitis in this guy who's immunosuppressed.
Yeah, I mean, I agree with all those things. We talked about ABCs. C is always COVID, So guy with bibasilar opacities, that's on the differential. I think I'm with you guys in some sort of like CNS process as well. What else am I thinking?
The leg is still cumbersome though, so I think like that's the thing we're trying to like tie into this as well.
Yeah.
So, and I think this is actually a really good start from the differential. I think only thing I would throw in is like MRSA with the MRSA bacteremia is just sepsis in general. But most likely with this guy's history, I would say probably MRSA is the next thing. So you got blood cultures, you got all these labs, you got urine cultures. What else do you want to do at this moment?
Oh, I thought there's one other thing. I mean, this would be a non-common situation, but it's definitely something to think about too. And a guy that presents untended new seizure, secondary to some other metabolic process in him, but is he presenting in postictal state? Just something definitely like, and he's obtunded from that. That's something to think about too, but I think, again, less likely.
Yeah.
In terms of what to do next, this gentleman I would probably consider an LP in him sooner rather than later. CT didn't seem to preclude us from doing that. He also might warrant an MRI of his head as well.
So the one I'm gonna just see what you think about this, Dr. Behan. What with his labs is a little bit concerning with doing an LP.
Let me see. Oh yeah, his platelet count. I forgot about that.
Yeah.
Still think he needs an LP, but
Yeah, I just don't think we can do it with a platelet of 7. I think
it doesn't change the fact that I think he needs an LP.
Yeah.
But can he get one this second? You're right. Probably not. No.
I agree. This guy definitely needs to get some brain fluid checked. But it's kind of obviously we're a little precluded at this juncture right now. So kind of in the acute setting, what would you do for this guy? Management, diagnosis.
Yeah, I think we got to start him on broad spectrum antibiotics. And I think we can start with antibiotics. I think, and so I would specifically do vancomycin and cefepime to start. And then I think I would have a pretty low threshold for introducing some fungal coverage as well, but I don't think we need to pull that trigger now. And then I totally actually agree with the MRI. I think the MRI is reasonable. And also considering maybe like I said, but I can only speak for myself. I keep forgetting about this leg, but getting some kind of advanced imaging of the lower extremities. So maybe even either like an arterial ultrasound that, that's not a perfect test. We could consider a CT angiogram. The only issue we're going to run into is he doesn't have a lot of room on his renal function, but I think if we're concerned about acute limb ischemia and it's a limb salvaging, diagnostic test, I think that's something to consider as well.
I would cover this guy for meningitis in particular. So I would add how old is he? Or like he's immune suppressed, definitely I would add antiviral coverage as well. What else did we talk about? I'm trying to think. Yeah. So yeah, I would cover him with that. I would cover him with AMP as well. And yeah.
And sorry, one quick thing before we move on. I misspoke on the bicarb. The bicarb's actually 18, and our gap is 18 as well. I think we're all on the right track, though, so it doesn't affect things, but it's important to note. And his lactate is 6.
Yeah, definitely give him some fluids. I think that's reasonable.
So just to keep up with time, Devang, what did you guys get any other imaging besides this chest X-ray and CT head? We talked about. Did you guys happen to get a CTA of his left lower extremity?
We didn't check out the left lower extremity. We did a CTPE though.
Yeah.
The CTPE was pretty interesting. I think this will probably just take us home. So it did not show a PE, but there was concern for ASD on that because there was some flow from the RA over to the LA.
Okay. Gotcha.
So what
did we get any other vascular studies after that?
No other vascular studies, but following up on that CT angio, we actually just did a bedside point of care ultrasound. And the RV looks a little big. And we also actually did an agitated saline study where we took some saline, made some bubbles with it, and just injected it into the venous supply. So we actually went into the, he's at this point got a central line in place. And we were able to see bubbles actually go from the RA over to the LA.
Devang, I can't tell you how impressed I am that you did your own agitated saline study. I just want to point that out.
It was not me. It was actually Jeremy Hua.
That's really awesome. Okay, cool.
It's pretty sweet.
So, just to summarize, Jason or Sean or Michelle, what do you guys have? What do you guys think right now about what's going on? How's this change your differential?
Well, I think it gives us a potential answer for, an etiology behind this perhaps like paradoxical emboli we're seeing. So stuff coming over from the venous system over into the arterial system could explain, the left lower extremity ischemia that we're seeing. As it relates to the obtundation, that's still pretty interesting. It's not completely unheard of, but it's pretty rare for a ischemic stroke to cause altered mental status. You really have to have it in the vertebral system. It really has to be a brainstem stroke. So again, if we capture that on MRI, great. If we don't, I don't know if I can like Occam's razor this back together. This might be Hickham's dictum instead. Yeah, so I'm definitely obviously concerned now about, paradoxical emboli from a right to left shunt.
This is new conference. It totally could be that,
So real quick, I just want to steer us back to the O2 sats of 40 to 80%. Are we doing something about that?
Yeah, that's a tough one. So you mentioned that, I'm trying to like put this all together.
shunting.
Yeah, so he's shunting a lot from the left to right.
It's right to left to right to left.
Yeah.
But
Right to left.
Yeah, so I think what they're so he's got a right to left shunt now is what it sounds like with like RV failure, RV dilation, right? So
Yeah.
So what did so I guess like Devang, why don't we just keep things moving? What did you guys do about that? What did you guys do in this next step? And like I guess like first off, did you guys end up getting an MRI of his brain?
So we did not. So we actually had intubated him. He got intubated before he got up to the McGee. And what was interesting was that on his ABG, things didn't improve a whole lot. So we were able to get his pH up to 7.3. His CO2 was 18, and then his PO2 was still in the 70s. So we did some improvement. His O2 sats still hung out like pretty low. They were still in the 80s. And so I think, considering the shunt, maybe we can just have our discussants describe what they're thinking in terms of why this shunt is maybe limiting his response to the intubation.
And he's getting deoxygenated blood into his main systemic vasculature.
Yeah, exactly. So there's actually a therapeutic move you can do here. I don't know if one of the discussants is thinking about it.
I'm not sure if you can, let's see, if you wanted to increase, so I would try something maybe like a Valsalva potentially. If you're dropping his, so things that would drop, like I'm thinking of things that might cause increased left to right is sort of what I'm trying to induce to maybe decrease the shunt. So I'm thinking sort of out loud, like if you decrease his preload, maybe, or like the right side, maybe that would increase his left, in ability of his left to shift towards his right. I would think that increasing afterload would, like things like a hand grip maneuver, squatting, those types of things would make it worse, but I could be backwards. on that. But that's how I know those things are affected. So those procedures would increase squatting or hand grip, increase afterload versus the Valsalva, or sort of having him stand upright from a lying down position in particular would decrease your preload. So I would think those would be the ones that might improve it done.
Yeah, those are really good ideas. Currently a little sedated. We can, oh, go ahead, Michelle.
Oh, no, I was just going to say I'm not quite sure, but is this when you would use like pulmonary vasodilators at all?
That is a really good call. So we did exactly that. We gave inhaled epoprostenol, and within a couple minutes, his O2 sats came up to 96%.
So, Devang, do you feel comfortable relating what exactly the point of?
Yeah, so the idea behind this inhaled epoprostenol is that the epoprostenol will dilate your pulmonary vasculature. That reduces the resistance to blood flow across the lungs. So this right ventricle now, instead of forcing things to go up into the right atrium and shunt across to the left side, now is able to actually get blood through the lungs a little easier, and that reduces the shunt fraction. So you have more oxygenated blood going over to the left side and less deoxygenated blood.
So I actually that's incredible. That's actually really cool. So, Devang, I want you, if you don't mind, because we've got about 7 minutes left, and just so we can get have a little bit more time for any teaching or questions that anybody wants to bring up and kind of recap. Could you kind of tell us what happened with this guy's course after you guys did all this, given the inhaled epoprostenol, improvement in his oxygenation, what ended up transpiring with him?
Yeah, so this was pretty interesting. This epoprostenol stayed on for a couple days, and he remained satting well. We did go ahead and diurese him. We thought that he was fluid overloaded, and that was resulting in RV dilation and just an inability of the RV to really squeeze well. So once we got him diuresed, he did better, and we were able to actually get him off of the epoprostenol. In terms of this shock picture, we thought it was likely more cardiogenic, so we actually got a central venous O2 sat off the central line. So when blood is not flowing well across the body has more time to remove oxygen from the blood, and so the central venous O2 sats were really low, like 50%. So it was more consistent with cardiogenic than septic shock. So this kind of left us a little puzzled, because he did have this fever of 100.4. And so we actually, and that's in the setting of all this immunosuppression. So we went ahead and treated him with vancomycin flagyl. He stopped having these like low-grade fevers. So we never quite figured out what was causing them. At the same time, now it's interesting that Jason mentioned the itises. One of the itises is myocarditis. So he had a troponin elevation to 9, and that kind of just lingered throughout his hospital course. We thought it was myocarditis because he had T-wave inversions kind of diffusely, V1 through V6. And I think at some point it began to involve the other leads. And so cardiology oncology was consulted and was following along closely. The jury's out on whether it was actually like induced by the nivolumab, but I mean, I think it was. And he ended up getting a right heart cath as outpatient once he was diuresed well, and he actually did a lot better. And his wife reported this was pretty interesting, that every time he went in for IVIG treatments, he got a huge fluid load, and he would actually go on BiPAP sometimes because he deoxygenated. So our theory was the RV was dilating and just not pumping well during those times.
So yeah, go ahead, Devang. Sorry, excuse me.
Oh, no,
I
was going to say something. I mean, it sounds like, at least my understanding of this is it sounds like this guy, he has like an ASD, right? That's his only cardiac defect that we've detected. And what you're telling me with this shunt is that he appears to have like Eisenmenger syndrome, where he is like, it's, which, you know, you don't always see in ASD in particular, so it's definitely a unique case, because he's got right to left flow to the point where it's causing a significant shunt and significant hypoxia, and that, I'm guessing, has resulted in some pulmonary hypertension as a result of that as well, which is why he responded to the
Exactly. His RVSPs on the echo at that point were actually like in the 40s, so they weren't that high, but they were high enough that he had this little like pop-off valve that he would be able to get some blood from the right side over to the left side and bypass the lungs.
Yeah, and so I think the interesting thing is kind of from what you're saying too. It sounds like he had an acute change in his. What it sounds like probably the acute change in his mental status was from the acute hypoxia. And I guess the question is why did this guy all of a sudden develop an acute right to left shunt, like just like that, and then become acutely hypoxic to the point that he had to get intubated? Did you guys ever kind of?
Yeah, you know, we never quite figured out why he became volume overloaded. We thought it was all from volume overload. He did have an ASD, we think, in the past. It just wasn't really being useful, like it wasn't causing a significant shunting fraction from right to left. And we never quite figured out what acutely caused this event.
Very cool. So what I wanted to do right now is I want Dr. Gergen to just kind of go over our big teaching points for the day, just to round us out for the next 3 minutes. And then we'll leave like a minute or two for any questions.
Awesome. So I think you guys all did fantastic. So a huge round of applause digitally for Devang for putting this case together, and then Jason, Sean, and Michelle. Awesome job. So I think some of the really good stuff you guys brought up is just that sick, not sick differential. You guys had that in mind throughout the case. And then some other really good stuff, you know, how do we think about checkpoint inhibitors? Always thinking about the itis to an organ system is a great teaching point that we all need to keep in mind. Thinking about hypoxia, that ABG, the chest x-ray, the EKG. And then when those things don't clue us in, like what do we look for next? And that's when we start going into our kind of rare differential, the shunt, the rare cases of EQ mismatch, stuff like that. I think we had a really good discussion about cool extremities, single versus multiple, asymmetric, grabbing a Doppler. And then I think Devang brought up some points. Me and Corey were in here like laughing to each other. Inhaled epoprostenol is a wild treatment. And so I think that's always a great thing to recognize. And the reason it works is if you're breathing in inhaled epoprostenol, it's going to the alveoli that aren't obstructed. And so you're going to get selective vasodilation in the alveoli that are aerated, which is why it's a selective vasodilator. So overall, I think Devang, you did an awesome job. This was a great case. And thanks so much for going through it with us.
Yeah,
My pleasure.
Yeah, big shout out to Jason, Sean, and Michelle for partaking with us. Thank you guys so much for being involved. You really did a great job.
This was great. Thanks, Devang. Thanks, everyone.
Thanks, guys. Thank you.